Suchitra madam, good evening.
Yes. Good evening. I can't see you.
There is some problem with my video.
Really?
Madam,
Okay.
President Kfog, welcome to
I've been also waiting for some time. Okay.
ഇപ്പൊ എല്ലാരും കയറണമല്ലോ മാഡം. ഇപ്പൊ തുറന്നല്ലോ. Sonia, good evening.
Good evening, madam.
സോണിയാണ് പ്രസന്റ് ചെയ്യുന്ന ആളല്ലേ?
അതെ മാഡം.
അതെ. Shekharan sir, good evening.
Good evening.
From international faculty.
Yes, for some time. I'm coming back on 12th anyway.
Madam said that back on 14th. I mean, you'll be here available on 14th locally.
Good.
So you had a good time there with your children?
Yeah, it was nice. Only thing I landed here in the thick of the winter. Now it is very pleasant anyway.
Okay.
Good evening, sir. So happy to see you.
So happy to see you anyway. fully busy and fully engaged. That is good. Going on with very good work. Let it go. Every year we are progressing. That is a good sign.
സാറ് എന്നെ കാണുമ്പോ ഒരു ആശ്വാസം, ഒരു സന്തോഷമാണ് ശരിക്കും.
വെറുതെ എന്നെ കൊണ്ട് ഇങ്ങനെ എന്നെ വിഷമിപ്പിക്കരുത്. ഞാൻ പണങ്ങിയുണ്ടാണെന്നൊന്നും പറയല്ലേ.
ആരും പണങ്ങിയിട്ടില്ല. We are all one. हम सब एक है.
അല്ലല്ല, ഞാൻ പറഞ്ഞതല്ല. എല്ലാവരും പറഞ്ഞു വരുമ്പോ സാറ് അന്ന് ക്ലാസ്സിൽ പണങ്ങി ഇതാണ് അത് മാത്രം ഞാൻ കേൾക്കാറുള്ളൂ എന്ന് പറഞ്ഞത്. തമാശയായിരുന്നില്ല.
അതെ.
Anyway, we have progressed very well in many fields, all the fields. Happy to see you all in this position. That is also there.
സാറിന്റെ ട്രെയിനിങ് ആണല്ലോ നമുക്കെല്ലാം കിട്ടിയത്. ഞാൻ സത്യം പറയാൻ ഫസ്റ്റ് സിസേറിയൻ സാറിന്റെ കൂടെയായിരുന്നു. ഒരുവിധം ഫസ്റ്റ് അല്ല, എന്റെ ഡെലിവറി ഫസ്റ്റ് ഡോക്ടർ എടുത്തത്. എല്ലാം കൊണ്ട് ഡോക്ടറോട് ഞാൻ ഭയങ്കര ഇൻഡക്റ്റഡ് ആണ്.
Thank you so much. Nice to hear such very good words.
അജിത് sir, good evening.
ജോയിൻ ചെയ്തോ?
ഞാൻ എയർപോർട്ടിലാണ്, അതുകൊണ്ട് സംസാരിക്കാൻ പറ്റുന്ന.
പറ്റുന്ന പോലെയൊക്കെ പറഞ്ഞാൽ മതി. പറ്റുന്ന പോലെ പറഞ്ഞ. എങ്ങോട്ടാ പോണേ അജിത്ത്? എവിടൊക്കെ പോണേ?
ഡൽഹിയില് സാറേ, ഡൽഹിയിൽ നിന്ന് വന്ന് തിരിച്ചു
വരുന്നു വഴിയാ. ഓക്കെ, ഗുഡ്.
Good evening, sir.
പ്രസന്ന മാഡം. പ്രസന്ന മാഡം,
Good evening.
ഒരു വലിയ കുപ്പുണ്ട്.
ഡോക്ടറെ.
Good evening, good evening. Ajit, good evening. Prasanna madam, good evening. Dr. Lakshmi, good evening.
Hi, good evening, Dr.
Shekharan sir, US.
ഗുഡ് ഈവനിങ്. ഓക്കെ, എവിടെയാണ്?
ഇല്ലല്ലോ, ദുബായിലാണ്.
ദുബായിലാണല്ലേ? അത് ശരി.
ഒരു എന്താ ഒരു എംബ്ലമുള്ള കോട്ടൊക്കെ കണ്ടുകൊണ്ട് ഞാൻ എവിടെയാണ്.
ഡോക്ടർ കുഞ്ഞുമൊയ്തീൻ, വിമല മാഡം പറയുന്നു മാഡത്തിന് ആ ഫാക്കൽറ്റി ലിങ്കിൽ ഓഡിയോ കാണുന്നില്ല എന്ന് പറയുന്നു.
ആണോ?
എന്താ മാഡം?
ഫാക്കൽറ്റി ലിങ്ക്
ഓഡിയോ
ഒക്കെ എല്ലാ സെയിം ഇതിൽ കൂടി നമ്മളെ കമ്പ്യൂട്ടറിൽ ഒന്ന് നോക്കാൻ പറഞ്ഞാൽ മതി.
മാഡം ലാപ്ടോപ്പിൽ കൂടെ ആണോ കയറിയിരിക്കുന്നത്? അതിന്റെ ലെഫ്റ്റ് സൈഡിൽ വരുമല്ലോ മാഡം, ഫാക്കൽറ്റി എന്ന് പറഞ്ഞിട്ട് വരുമല്ലോ.
വിമലക്കാണോ?
വിമല മാഡത്തിന്. മാഡം എന്നാ മൊബൈലിൽ കൂടെ കയറി നോക്കിയേ.
കമ്പ്യൂട്ടറിന്റെ സൗണ്ട് കുറഞ്ഞ എടുപ്പുണ്ടോന്ന് അറിയില്ല. അതിലൊരു സ്പീക്കർ ഉണ്ട് കമ്പ്യൂട്ടറിൽ.
ജോയിൻ വിത്ത് കമ്പ്യൂട്ടർ ഓഡിയോ എന്നുള്ളത് ക്ലിക്ക് ചെയ്യാത്തോണ്ടാണോ?
എല്ലാവരും സ്വയം പേര് അടിക്കുവോ സാറേ?
ഞാൻ അങ്ങനെ പേരും
ആ 3 dots ഇല്ലേ, അപ്പർ റൈറ്റിലെ 3 dots ക്ലിക്ക് ചെയ്ത് കഴിഞ്ഞാൽ റീനെയിം എന്നുള്ള ഓപ്ഷൻ വരും.
അതങ്ങോട്ട് പോയി കിട്ടിപ്പോ ഏതായാലും.
മോളിലത്തെ റൈറ്റ് കോർണറിൽ ഒരു 3
സാധനം പോയിടോ, ഞാൻ നോക്കട്ടെ, എടുക്കട്ടെ.
അല്ല, അവിടെ കൊണ്ടുവച്ചാൽ അത് വർക്കാവുള്ളൂ. സാറിന്റെ ഫോട്ടോന്റെ മേലെ കൈ വെക്കണം.
ഇല്ലെന്നേ.
സാറിനെ കൈ വെക്കരുത്, ഫോട്ടോന്റെ മേലെ കൈ വെക്കുക. പ്രസന്നമാര് മാഡം പേര് മാറ്റണ്ടേ?
ആ പേര് മാറ്റാം. പേരില്ലേ?
പേര് ഫാക്കൽറ്റി എന്നാണ് പേര് കാണിക്കുന്നത്.
ഞാൻ റീജോയിൻ ചെയ്യേണ്ടി വരും. നോട്ടെ.
ഇല്ലില്ല സാർ,
ശരി ശരി.
ഫോട്ടോ ഉണ്ട്.
ഓക്കെ ഓക്കെ.
അതിൽ ക്ലിക്ക് ചെയ്ത് ആ റീനെയിം എന്ന് പറഞ്ഞൊരു ഓപ്ഷൻ കാണും.
ആ
ഒരു
കാണുന്നുണ്ട്.
മിനിറ്റ് ഡോക്ടർ
ആ
കുഞ്ഞുമൊയ്തീൻ.
റീനെയിം എന്നുള്ളത് ക്ലിക്ക് ചെയ്ത് ഞാൻ സാറിന്റെ പേരടിക്കാം.
ഞാൻ റീനെയിം ചെയ്ത്.
ഒരു സെക്കൻഡ് സാർ, ഒരു സെക്കൻഡ്. ഡോക്ടർ കുഞ്ഞുമൊയ്തീൻ വിശ്വനാഥൻ സാറിനും ഓഡിയോ വീഡിയോ വരുന്നില്ല. വിമല മാഡത്തിന്റെ വന്നല്ലോ.
അതെ കാണാം.
അത് അവരുടെ ടെക്നിക്കൽ ഇഷ്യൂ മാഡം.
ഏ
അവരുടെ ആ കൺസേൺഡ് ആൾക്കാരുടെ ടെക്നിക്കൽ ഇഷ്യൂ ആണ്. നമ്മളൊക്കെ സെയിം ലിങ്കിൽ കൂടെ ജോയിൻ ചെയ്തത്.
സാറിന് നമ്മൾ പറയുന്നതൊക്കെ കേൾക്കുന്നുണ്ടോ സർ?
അല്ലെങ്കിൽ മിക്കവാറും അവര് ഡെലിഗേറ്റ് ലിങ്കിൽ കൂടെ ജോയിൻ ചെയ്യുന്നുണ്ടാവും. ഫാക്കൽറ്റി ലിങ്കിൽ കൂടെ ജോയിൻ ചെയ്യാൻ പറയണം.
അല്ലല്ല, ഫാക്കൽറ്റി മാത്രമേ അയച്ചിട്ടുള്ളൂ അവർക്ക്. വിശ്വനാഥൻ സാറിന്റെ ഫാക്കൽറ്റി മാത്രമേ അയച്ചിട്ടുള്ളൂ.
ബ്രോഷറിലുണ്ട് മറ്റേത്, അതിലെങ്ങാൻ കയറിയെന്ന് അറിയില്ല.
സർ ഞാൻ അയച്ചിരുന്ന
ഫാക്കൽറ്റി ലിങ്ക് ഒന്നുകൂടെ ക്ലിക്ക് ചെയ്യാൻ പറയും.
ഞാൻ സാറിന് അയച്ച ഫാക്കൽറ്റി ലിങ്കില് വിമല മാഡത്തിന് സർ മൊബൈലിൽ കൂടെ ഒന്ന് കയറി നോക്കിയാലോ? ശരി ശരി സർ.
സാർ എന്നാ സാർ വരുന്നത്?
ഞാൻ 14th അവിടെ എത്തും. ഏതായാലും കുറെ നാളായി. നിങ്ങൾ അതിൻ്റെ ഇടയ്ക്ക് ഒരു മീറ്റിങ്ങിന് പറഞ്ഞല്ലോ, ഞാൻ റിപ്ലൈ ചെയ്തിട്ടുണ്ട്. എന്നായിരുന്നു അറിയില്ല. 29.
അവരുടെയൊക്കെ ശരിയായി. വിശ്വനാഥൻ സാറിനും കിട്ടുന്നില്ല എന്ന് പറഞ്ഞു. ഇപ്പൊ ഡോക്ടർ ഹരിപ്രസാദും പറയുന്നു ഓഡിയോ വീഡിയോ കിട്ടുന്നില്ല എന്ന്.
ഓഡിയോ വീഡിയോ കിട്ടാത്തത് പാനലിസ്റ്റ് അറ്റൻഡ് ചെയ്തിട്ട് ജോയിൻ ചെയ്തിട്ടാണ്. അവരോട് ലോഗ് ഔട്ട് ചെയ്തിട്ട് ഫാക്കൽറ്റി ലിങ്കിൽ ജോയിൻ ചെയ്യാൻ പറയും.
ഒന്ന് ലോഗ് ഔട്ട് ചെയ്തിട്ട് ലോഗിൻ ചെയ്ത് നോക്കിയേ. വിമല മാഡത്തിന് ഇങ്ങനെ ഫെയിൻഡ് ആയിട്ട് കാണാം.
ഇവിടെ 2 ഡിവൈസ് ഓപ്പൺ ചെയ്തിട്ടുണ്ടായിരുന്നു. ഫോണും കമ്പ്യൂട്ടറും കൂടെ ഓൺ ചെയ്തിട്ടുണ്ടായിരുന്നു. അതാണ് എക്കോ വരുന്നത്. അതുകൊണ്ടാണ്.
അത് 2 എണ്ണത്തിൽ കൂടെ ജോയിൻ ചെയ്തിട്ടുള്ളതാണ്.
അതെ. തുടങ്ങിയ ആളുകൾക്ക് പിന്നെ സംശയവും ഇപ്പോഴല്ലേ എന്നൊക്കെ.
ഡോക്ടർ കുഞ്ഞുമൊയ്തീൻ അവിടെ എന്തെങ്കിലും കോൺഫറൻസിന് പോയതാണോ അതോ പിന്നെ ഓപ്പറേറ്റ് ചെയ്യാൻ പോയതാണോ?
മാഡം OP ഉണ്ട് മാഡം. ഇവിടെ എല്ലാ മാസവും OPക്ക് വരും. OP ഉണ്ട്, സർജറി ഉണ്ട്.
ARMC ഉണ്ട് അവിടെ.
അല്ല, നമ്മളൊരു അസോസിയേറ്റഡ് ക്ലിനിക്കാണ് സാർ.
ശരി.
എന്നെ ഒരു ഇന്റർനാഷണൽ കോൺഫറൻസിന് കീനോട്ട് സ്പീക്കറായിട്ട് വിളിച്ചതാ, ഞാൻ പോയില്ല. അത് ഈ കാല് വയ്യാതൊക്കെ പോവാനൊക്കെ പഠിച്ചിട്ട് ഞാൻ ഇപ്പൊ പക്ഷെ എനിക്ക് കാലിന് വലിയ കുഴപ്പമില്ല. ഞാൻ ഇങ്ങനെ ആവുമെന്ന് ഞാൻ പ്രതീക്ഷിച്ചില്ല, അതുകൊണ്ട് ഞാൻ കളഞ്ഞതാ.
എന്തിനാ നെഗറ്റീവായിട്ട് ചിന്തിക്കണം? ഇടയ്ക്കിടയ്ക്ക് അങ്ങനെ പോണേ എന്തിനാ?
പോകേണ്ടതായിരുന്നു. കീനോട്ട് സ്പീക്കറായിട്ട് വിളിച്ച് ഹോട്ടൽ അക്കോമഡേഷൻ എല്ലാം തന്നതായിരുന്നു, പോയില്ല.
വേണം സ്റ്റാർട്ട് ചെയ്യല്ലേ?
ഒരു മിനിറ്റ്, ഡോക്ടർ ഹരിപ്രസാദും ഡോക്ടർ വിശ്വനാഥനും കൂടെ ജോയിൻ ചെയ്യണമല്ലോ, എന്നാലേ നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാൻ പറ്റും.
ഹരിപ്രസാദിനെ കാണാനേ ഇല്ലല്ലോ ഈ പറഞ്ഞ പോലെ.
അല്ല, അദ്ദേഹത്തിന് ഓഡിയോ വീഡിയോ പ്രശ്നം. വിശ്വനാഥൻ സാറിനും ഓഡിയോ വീഡിയോ പ്രശ്നം.
നമുക്കൊന്നും ഇല്ലാത്ത പ്രശ്നം.
ഫാക്കൽറ്റി ലിങ്കിൽ കേറാൻ പറ. പിന്നെ ലക്ഷ്മി
ശരിയായോ?
ഫാക്കൽറ്റി ലിങ്കിൽ കൂടി കയറാൻ പറയും. മറ്റേ ഒരു സ്ലൈഡില്ല, ആ സ്ലൈഡിൽ കൂടി നമ്മള് ബ്രോഷർ അടിച്ചാലൊക്കെ ഇവിടെ കയറിയിട്ടുണ്ടെങ്കിൽ കിട്ടൂല. പക്ഷെ ഡെലിഗേറ്റ്സിന്റെ ഓപ്പൺ ആണ്. അവരോട് ഒരു മെസ്സേജ് എന്തെങ്കിലും പറയൂ, വിൽ ബി സ്റ്റാർട്ടിങ് ഇൻ 5 minutes എന്നോ 2 minutes എന്നോ. അല്ലെങ്കിൽ ഡെലിഗേറ്റ്സ് കയറിയിട്ടുണ്ടെങ്കിൽ അവർക്ക്
ടെക്നിക്കൽ പ്രോബ്ലം ആണെന്ന് പറഞ്ഞാലോ.
അതൊരു 2 minutes കഴിഞ്ഞ് ഓൺ ആവുമെന്ന് പറയും. അല്ലെങ്കിൽ നിങ്ങൾക്ക് ആരെങ്കിലും ഹെൽപ്പ് ചെയ്യാനുണ്ടോ അവിടെ ആരെങ്കിലും ടെക്നിക്കൽ?
നമ്മളൊക്കെ തന്നെ മതി സാർ. ലക്ഷ്മി പറ ലക്ഷ്മി. ഈ ലണ്ടനിൽ ചൂടാ, മുമ്പൊക്കെ ഭയങ്കര ചൂടാണെന്നും.
ഡോക്ടർ പ്രസന്നയുടെ മൊബൈൽ ഓൺ ആണോ? ആരുടെയോ ഒരു 2 ഡിവൈസ് ഓൺ ആണെന്നുണ്ട്.
എന്റെ ഡിവൈസ് ഓണൊന്നുമല്ല.
എനിക്ക് തന്നെയാണോ? എനിക്കല്ലോ.
സാറിന്റെ ആണോ?
ഞാൻ ക്ലോസ് വേണ്ടി വരുമോ? കയറേണ്ടി വരും. ഡോക്ടർ ഹരിപ്രസാദ് വന്നല്ലോ.
ഹരിപ്രസാദ് വന്നു.
ഫോണിൽ കൂടിയാ കയറിയെന്നാണോ അവസാനം?
ഇനിയിപ്പം വിശ്വനാഥൻ സാറും കൂടെ കയറിയാൽ നമുക്ക് തുടങ്ങാം.
ഓ യെസ്.
ഹരിപ്രസാദ് റീനെയിം ചെയ്യോ? ഫാക്കൽറ്റി എന്നുള്ള റീനെയിം ചെയ്തിട്ട്
കിട്ടിയിട്ടുണ്ട്.
ഇല്ല, ആ 3 dots ക്ലിക്ക് ചെയ്തിട്ട് റീനെയിം ചെയ്തോ?
3 dots ക്ലിക്ക് ചെയ്തിട്ട് റീനെയിം ചെയ്യാൻ പറ്റുന്നില്ല.
പറ്റും.
ക്ലിക്ക് ചെയ്യുമ്പോൾ റീനെയിം ഓപ്ഷൻ കാണും, അതിൽ ക്ലിക്ക് ചെയ്യണം.
അതിലെഴുതണം,
അതിൽ ടൈപ്പ് ചെയ്യണം.
സർ മൊബൈലിൽ കൂടെ നോക്കാമോ സർ? ഡോക്ടർ
ഹരിപ്രസാദിനെ കണ്ടല്ലോ. ഡോക്ടർ വിശ്വനാഥനാണ് ഇനി വരാനുള്ളത്.
അല്ല, വിശ്വനാഥൻ സാറിന് മൊബൈലിൽ കൂടെയും കയറാൻ പറ്റുന്നില്ല.
അയ്യോ, ലിങ്ക് ഒന്നും കൂടെ അയച്ചു കൊടുക്കൂ.
ലിങ്ക് ഒന്നുകൂടെ അയച്ചു കൊടുക്കും.
ഫാക്കൽറ്റി ലിങ്ക് ഒന്നും കൂടെ അയച്ചു കൊടുക്കും.
ഫാക്കൽറ്റി ലിങ്ക് ഞാൻ സാറിന്റെ മെയിലിലേക്ക് ഒന്നും കൂടെ അയക്കാം.
We are just waiting for one more faculty to join and we'll be starting immediately. Thank you.
നിയർലി 200 people ജോയിൻ ചെയ്തിട്ടുണ്ട്. അധികം ലേറ്റ് ആകണ്ട.
190.
ഇനി ലേറ്റ് ആകണ്ട.
നമുക്ക് കേസ് അയച്ചു കൊടുത്തിട്ടുണ്ടല്ലോ. തുടങ്ങിയാലോ ലക്ഷ്മി?
ഏതായാലും കുറച്ച് സമയം കിട്ടിയോണ്ട് ആള് ജോയിൻ ചെയ്യണം. 200 ആയിക്കോളും.
ലിങ്ക് അയച്ചിട്ടുണ്ട് സർ, അതിനകത്തൂടെ ഒന്ന് കയറി നോക്കൂ.
ഡോക്ടർ വിമലക്ക് പറ്റിയോ കയറാനായിട്ട്?
വിമല മാഡം ഉണ്ടല്ലോ.
മാഡം ഉണ്ട്.
ഓക്കെ, ഗുഡ്.
ഞാൻ വിശ്വനാഥൻ സാറിന് ഒന്നും കൂടെ അയച്ചു കൊടുത്തിട്ടുണ്ട്. അപ്പൊ സാറിന് കയറാൻ പറ്റുമെങ്കിൽ കയറിട്ട് നമുക്ക് തുടങ്ങിയാലോ എന്നാ?
we will start ലക്ഷ്മി. ഞാൻ വിളിക്കുമായിരുന്നു ലക്ഷ്മിയെ. നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാം. കേസ് അയച്ചു കൊടുത്തിട്ടുണ്ടല്ലോ.
ആൾക്കാരെ ഡ്രോപ്പ് ചെയ്യാം.
We'll start ലക്ഷ്മി.
yes. Madam, can you see my slide?
Yes.
Yes.
Okay, madam. So good evening, all of you. We start this year's session. Okay, we already had a session in January, and this is the first session of the new elected Kfog committee. And this is under now Mdnmsr has become a subcommittee under the Safe Motherhood Committee. So 1 second, the slide marunilla. Okay. And so the Safe Motherhood Kfog, the Safe Motherhood Committee, Mdnmsr subcommittee welcomes you all, the delegates and the faculty for the Kfog Mdnmsr Case Connect webinar series 3. And before I start, on behalf of all of you, I say a namaskaram to Dr. Paili sir, who is not in the present meeting and who is the brain behind our Mdnmsr activities and who's the one who made it so popular among all of us and made it into such a useful academic program for all of us. And I should say a big welcome to all the Kfog officials, Dr. Sujitra Sudhir, the president, Dr. Subhash Malya, secretary. He is not able to join because he's out of India. And Dr. S. Ajit, the state coordinator, Dr. Kunju Moideen, who is the coordinator of the webinar series and who was very prompt in responding, giving us, supporting us with the link, flyer, etc. And then we have our dear chairperson, Dr. B. Prasanna Kumari. We are expecting a lot of activities under her guidance, and there's no need for any introduction to Prasanna Madam to the crowd of Kerala, to the gynecologists of Kerala. She's a great teacher, great academician, great surgeon. She has written a book for the postgraduates, always interested in spreading knowledge. And we are very happy to have you, Madam, as the chairperson of the Safe Motherhood Committee. And now we come to the experts. P.K. Shekharan sir, again, does not need any introduction to this crowd. A very, very dear teacher for all of us. He was the professor and head of the department at Calicut Medical College. And he has done exemplary work on gestational trophoblastic disease. But more than that, he is dear to us as a great teacher for all the gynecologists of Kerala, a very friendly, approachable sir. And he's a constant presence in our CRMD meetings. And then Dr. Hariprasad. Dr. Hariprasad is the chief consultant at Kannur, and he's a very active member of the CRMD and the captain of the Mdnmsr at Kannur. Very, very prompt in conducting all the Mdnmsr meetings, sending us the minutes and responding at each and every call. Now we come to our great experts other than the gynecology. Vimala Madam, she's always there. Just one phone call is needed, and if she's free, she's very willing to come. And she also tells us that it's a great opportunity for her to revive her knowledge in obstetrics. And we welcome you, Madam, to this meeting. And then Dr. Vishwanath N. And he is the professor of medical gastroenterology at Trishur Medical College. And we have heard him talk a lot during our CRMD meetings at Trishur. Anything in connection with liver and pregnancy, he's an expert. And unfortunately, he is not able to join till now. I hope as time goes, he'll be able to join. And now Dr. Sonia C. Alphonse, who is the assistant professor in ONG at Kottayam Medical College. And always, she's very prompt. Kottayam as such is a district very prompt in conducting Mdnmsr meetings and sending us the minutes. And Sonia in special always responds whenever you call her. The next moment she is there with all the help, and she will be the one who is presenting the cases. With all this, I welcome you. We begin the case series. Thank you. Prasanna Madam, you want to say anything as an introduction?
No, respected Chair sir, Dr. Kunjumaideen, Dr. Ajit, Dr. Sujitra Sudhir, Vimala, Dr. Hariprasad, Dr. Vishwanathan, and Dr. Sonia. Welcome to this webinar series. This webinar series actually, namaskaram to Paili sir, because sir only conceived all these ideas and executed all these, and it is going to, I think, of all the programs Paili sir has conceived, Mdnmsr is going to make a difference. That's what I feel, because it will reach the grassroots level. Even if we do CRMD, we sit together and analyze, spend days together analyzing the case sheets and then discussing in the CRMD meetings. It will not reach the periphery. It has not reached the periphery, but the Mdnmsr will reach the periphery. And that is why I think that it is the best program conceived and executed by Paili sir. So namaskaram to Paili sir. And my idea is to bring this forward. And my motto is not even a single preventable maternal death, because we have almost controlled death due to hemorrhage, hypertension, and even sepsis, not that much. But still rare diseases are coming up and rare situations. Even in these AFLP or HELP syndrome of hypertensive disorders, rare situations will come with serious problems. And we have developed so much so that we have facilities for even transplant available if you want to. So ICU facilities have improved so much. So I think it's high time that we should make benefit of all these facilities and reduce our preventable maternal deaths to 0. So let us start. Let us start, Lakshmi.
We will, I think, Dr. Sonia.
Okay, case, madam. I will
You can
start.
we can start the case discussions. You can share your slides.
Okay, madam. Thank you.
Sir.
Let me share. I'm sharing. Madam, am I audible? Can you see my slides? Hello?
We can't see your slides, but you are audible. Share screen. Have you minimized the program in your computer?
Okay, madam, I will do.
Okay.
Is it audible? Can you see my slides now?
Yes.
Yes.
Okay. Good evening to all. Let me thank Kfog, Mdnmsr subcommittee and Dr. Lakshmi Ammal for giving me this opportunity. And there are 2 cases. First case is Mrs. X, 36-year-old, G4P2L1, case of previous 2 CS, was admitted 31 weeks and 6 days of gestation. And she became near miss on the next day of admission and was discharged on 17th day. And coming to the history, she was a known case of gestational hypertension since 1 week. She was referred from private hospital as a case of severe preeclampsia with a BP of 260/170 millimeters of mercury with impending symptoms. She had epigastric discomfort and multiple episodes of vomiting. She was given tab Lavatolo 100 mg and tab Nicardia 10 mg start from local hospital, and injection magnesium sulfate loading was given and before referral. And her pregnancy was detected at 8 weeks and had regular antenatal checkup. Detected gestational hypertension at 31 weeks, that means about 1 week back, and was started on tab Nicardia 10 mg BD. Her antenatal investigations were within normal limits, and USG was also within normal limits. She had regular cycles. She was married at the age of 19 years, which was non-consanguineous, and it was a spontaneous conception. Her first pregnancy was a term LSCS done for FGR, oligohydramnios, and baby weight 1.8 kg, and that was 15 years back. Her second pregnancy was also a term LSCS done for previous year's oligohydramnios. Baby weight 2.4 kg, and it was 11 years back. And third was a spontaneous abortion at 6 weeks, which was managed medically. She gives family history of cardiovascular disease, and her father had diabetes mellitus, coronary artery disease, and cerebrovascular CVA. And on admission, patient was conscious, oriented, and lethargic. Her BMI was 27.5. There was no pallor. Bilateral pedal edema was present. Pulse rate was 82 per minute. And her BP was 210/110 millimeters of mercury at admission, for which injection labetalol 20 milligram IV was given. 20 minutes later, repeat BP also was elevated 180/120 millimeters of mercury, for which injection labetalol 40 milligram IV was given. After 20 minutes, BP became 140/100 millimeters of mercury. And her systemic examination was within normal limits. Obstetric examination showed 28-week size uterus, cephalic presentation with good fetal heart sounds. There was no ascites, and there was cervix was long and was closed. NST showed a category 2 type, and magnesium sulfate regimen was continued after admission. The investigations after admission showed HB was 12.1, platelet count 1.12 lakhs, and uric acid was 10.5. Her bilirubin was elevated, total 1.2 milligram, and SGOT, SGPT was in the range of 1030 and 1040. Total protein was 5.9 gram percentage and albumin 2.9. LDH was 546, and sodium and potassium was normal. So investigation at the time of admission showed a thrombocytopenia and elevated liver enzymes and elevated bilirubin, suggestive of HELP syndrome. In view of HELP syndrome and category 2 NST, emergency LSCS with sterilization was done under spinal anesthesia on second day after admission. Delivered a non-asphyxiated preterm female baby weighing 1.64 kg at 2:06 a.m. on the next day. Intraoperatively, there was dense adhesions between anterior abdominal wall and anterior surface of the uterus, which was released, and additional hemostatic switches were applied. Coming to post-op day 1, patient was conscious and oriented. There was no pallor, but there was pedal edema, and BP was 140/100. Per abdomen, uterus was contracted and retracted, and the urine output was only 300 ml over 5 hours. That means about 60 ml per hour. The investigations showed hemoglobin was 11.6%, TC was 14,000, platelet was 61,000, which was 1.12 on the previous day. But the RFT, blood urea and serum creatinine was normal. Serum uric acid was 7.2. Electrolytes showed a hyperkalemia. Potassium was 6.3. And there was marked increase in serum bilirubin. It was 1.2 at the time of admission. Now it was 9.3. Total was 10.3 and conjugated 3. And serum protein almost remained the same range. SGOT, SGPT was 1,190 and 1,720. There was a mild elevation in liver enzymes. LDH was normal. PTIN and APTT was also normal. Urine PC ratio was 13.9. Urine albumin was 3+. Serum magnesium was 4. Peripheral smear showed thrombocytopenia. And manual platelet count was 40,000. Normal was 61,000. Manually it was only 40,000. And urine culture was sterile. Patient was monitored in HDU, and antibiotics started injection cefuroxime and injection metrogel. Antihypertensives, tab Nicardia XL 30 mg BD, tab Lavatilo 200 mg TAD, and Apraso 25 mg TAD was started. Magnesium sulfate was stopped in view of raised blood urea, hyperkalemia, and reduced urine output. Thromboprophylaxis was given by DVT pump. Gastromedicine consultation was done. Advised also ursodeoxycholic acid 300 mg BD, and to monitor LFT, INR, and loose enema. Nephrology consultation was also done. The diagnosis was AKI stage 3, probable HELP syndrome. Advised anti-hyperkalemic measures, and to limit intake to output plus 300 ml. And also advised injection last is 40 mg TAD and albumin correction. 4 unit PRC, 3 unit cryoprecipitate, and 3 unit FFP was given. On post-op day 2, the general condition was fair. She was febrile. There was pallor, mild pallor. Icterus was present, but there was no flapping tremors. BP was controlled. Per abdomen, there was distension. Uterus was contracted, but the urine output was only 25 ml per 12 hours. So there was drastic reduction in the urine output. The investigations showed HB of 8.4 and platelet count was 42,000, which was 61,000 on the previous day. And blood urea and serum creatinine was elevated, 90 and 2.6, but which was normal on the previous day. And so potassium was 4.5, serum bilirubin 9.5 and 3.5, which was remained almost the same range. And there was hyperproteinemia, HB, total protein was 4.6 and albumin 2.5. SGOT, SGPT showed an improving tendency, 648 and 614, while on the previous day it was in the 1,000 range. LDH, PTA was also normal, urine PC ratio 13.9. So second day, RFT started worsening with decreased urine output and LFT showing mild improvement. And there was decrease in thromboplatelet count also. Post-op-day 2, on the same day, arterial ammonia was done. It was 133. Serum magnesium was 4. N-terminal pro-B-type natriuretic peptide was 747. Hepatitis A, hepatitis B, and hepatitis B viral markers were negative. HIV was negative. Blood culture was sterile. Ultrasound abdomen and pelvis showed right mild pleural effusion. Bilateral raised renal echoes and raised liver echoes. SPA Doppler was normal. Nephro-V was done. Advanced hemodialysis. 1 unit PRC and 4 unit platelet transfusion was given. Cardiology consultation done. Advised to continue antibiotics. And their impression about NT-proBNP, they said that it may be false positively elevated. And first hemodialysis done on post-op done. And post-op day 3, patient general condition was fair. She was febrile, having pallor and icterus. BP was 140/100. And on third day, the inflammatory markers showed a slight increase in trend with procalcitonin 16.59 and CRP 57.1. Surgery consultation done for abdominal distension. They advised nil per orally, RT, rails tube aspiration and ambulation. Antibiotics changed to injection piptas 2.25 milligram eight-hourly half dose because of the worsening renal function. This is the investigations. TC was increasing 19,000, platelet count 64,000, which showed a mild increase. But the blood urea and serum creatinine was worsening 143 and 4.6. And bilirubin and SGOT, SGPT liver function test showed improvement. So on the fourth day, liver function and platelet count showed improvement while the RFT worsened. Post-op day 2, on post-op day 4, second hemodialysis was also done. Oral SIP started and rails tube removed. Investigation showed increasing trend of the platelet and improving bilirubin and SGOT and SGPT. It was only 2.3, bilirubin was 2.3, and SGOT, SGPT in the range of 85 and 196. But the blood urea and serum creatinine was 139 and 4.9. Coagulation profile was normal. Hemodialysis continued and total 4 hemodialysis done on alternative days. And on 2nd, 4th, 6th, and 8th post-operative day. And on 10th day, urine output was 1,300 ml per 24 hours. Output improved. And nephro-review done. There was no need for further hemodialysis. And patient shifted to ward with advice to monitoring blood pressure, renal function test, INR, serum electrolytes, and intake and output. On post-op day 12, all investigations were normal except for blood urea and serum creatinine, which remained in the range of 160 and 4.7 milligram percentage. On 17th post-op day, blood urea and serum creatinine was from 146 and 2.4 milligram percentage, and sodium and potassium was within normal limits. And patient was discharged on post-op day 7 after obtaining nephro fitness. So this is a final diagnosis: P3L3, severe preeclampsia, HELP syndrome, aka stage 3. The near-miss criteria, category 1.1, pregnancy-specific obstetric and medical disorders. The disorder is hypertension. The symptoms and signs include impending symptoms of epigastric pain. BP was 160/110. Investigation showed proteinuria more than 1 gram per ml. Serum creatinine 3.5 milligram per deciliter. Serum bilirubin 6 milligram per deciliter. And ALT and AST more than 100 international units per liter. The interventions include hemodialysis and multiple transfusions. So this is the case. This is a case of severe preeclampsia with HELP syndrome and acute kidney injury, which was managed well by multidisciplinary team, and the patient was discharged on POD 17 in good condition. So this is the case. And now moving on to the discussions.
Can you have the discussion on the first case? Otherwise, people will be confused.
Yes, sir. Yes, sir. So
Okay.
moving on to the discussions, with chairperson's permission, I call upon Dr. Hariprasad, state expert, for giving his expert opinion. Sir, please. Dr. Hariprasad.
Yes. Good evening, everybody. respected seniors, teachers, colleagues, it gives me great pleasure to welcome you all in this important case discussion. I would like to begin by appreciating Dr. Sonia Alfonsi for presenting such a compelling and thought-provoking case of an obstetric near miss. We usually have this type of cases in the real life. And I would please remember the goal of our discussion is not to assign blame, but to promote open dialogue and improvement of such scenarios. To summarize briefly, this case highlights a critically ill patient with preeclampsia with severe features, HELLP syndrome, and acute kidney injury. Fortunately, the patient survived due to aggressive multidisciplinary management. However, it offers us several learning opportunities. The role by the multidisciplinary team should be, it's a very nice case. They managed the case very well. And actually, I want to discuss what are the opportunities we get so that the patient won't go to this near miss category. That's what I'm going to discuss. First of all, the patient missed the early screening for preeclampsia. She had a history of fetal growth restriction in the first and second pregnancies, fetal growth restriction, oligohydramnios. Certainly, this reveals that there is placental dysfunction. The need for first trimester screening for preeclampsia and growth restriction to all obstetric patients is relevant in such cases. I would also like to screen her for APLA syndrome also. So that if you screen, because I also noticed that the patient passed the screening window, that is, the screening is usually done 11 to 14 weeks, but the ultrasound seemed to be done after 14 weeks. So she could not do the screening, but we have another option, that is justosis score. At least we should get some history from the patient and do a mean arterial pressure and triage the patient whether she is high risk for preeclampsia or not. If she is in high risk, we can do aspirin prophylaxis, which is also she missed. If you give a low dose aspirin, it may not prevent the whole preeclampsia, but severe symptoms, severe diseases can be prevented, like HELLP syndrome, and the severe outcome she won't be in the severe type diseases. I also noticed she was not properly screened for gestational diabetes. Her fasting blood sugar was 107. There was no report on GCT or GTT. She is more than 35 years with a family history of diabetes, all those things. We have to screen her properly for GDM also. Another thing I found that the response to gestational hypertension, when she was diagnosed as hypertension at 30 weeks of gestation, actually it was an early onset preeclampsia. we should consider it as a very serious condition. She should have observed in the hospital itself, watch for any organ dysfunction, and detailed evaluation should be done so that we can pick up early these problems and manage little more aggressively, little bit earlier itself. Another thing I noticed was the patient was detected high BP from the referring hospital. It was 260/170 with impending symptoms. But she received only tablet labetalol 100 milligram and tablet Nicardia 10 milligram and an injection loading dose of magnesium sulfate. This BP should be aggressively treated from the referring hospital itself. We have to give injection labetalol just like when the patient received at that tertiary care center. How the BP is managed. Just like that, the BP should be controlled from the referring hospital itself. Luckily, she didn't have any cerebral bleeding with this high BP. These are the things I just noticed from the point of management. We could have little more careful in such high-risk patient so that these type of conditions, that is gestational hypertension and all, we should be careful and watch for any signs of serious symptoms. These are the things I have noticed. Any comments?
Thank you, sir. Thank you for your expert learning points. Now I invite Dr. Shekharan sir, to give more insights into the case from an obstetrician's point of view. Welcome, sir. Shekharan sir.
Thank you, Sonia. Thank you, Lashmi Ammal. Respected colleagues, I am very happy to see that this case was managed when she developed the complications. As Dr. Hariprasad was telling, we should offer the screening for all the things in the first trimester itself, because now the antenatal care, as we know it, it is something what is known as the inverted pyramid of care. You do everything in the first trimester and try to pick up the cases that may having the risk. So likewise, even if you don't do the complete thing, at least clinical history, physical examination, a well done MAP, and you put it on the software which is freely available, you will see the risk. And if the risk is 1 in 100 and above, you just start the aspirin, which is a simple treatment. You can prevent at least 30% of these cases of preeclampsia going for such a severe form. So that is one missed opportunity. Now, I said I am happy because the case is managed very well when she developed all the complications. I am happy about the way the patient was referred, even though Hariprasad said that she should have been given parenteral labetalol, but I am not very critical that way. They have given the loading dose of magnesium sulfate and 2 antihypertensives. The nifedipine is as good as injection labetalol. I mean the plain nifedipine. It will act within 10-15 minutes as an IV preparation also. So it's not bad. That referral was very good, perfectly in order, but they might be having some fear about IV hypotensives and other things. So at least nifedipine was there. If it is a plain nifedipine, that is good enough. Reaching to the next center, everything is done very clearly, and a sudden recognition of the seriousness of the case and the diagnosis of HELLP syndrome, which can lead to all the problem, and termination of the pregnancy immediately by cesarean section. My only point is that when you are taking a patient for cesarean section, even if she had a platelet count done the previous day or the day in the morning, please repeat the platelet count, because the platelet count thrombocytopenia can worsen within hours. And at least if it is not 50,000, you are venturing on to a cesarean section may lead on to bleeding and other complications. So try to make it up to at least 70,000 or at least 50,000. So that is one point. Secondly, when you are doing a cesarean section for a HELP syndrome, fearing the problem, you may go in for a midline vertical incision. I don't know what was the incision here. There was previous 2 cesarean, that's okay. Still you can go for a vertical incision because many cases we had hematoma developing and reopening and the DIC and even losing the patient. So that is one point which may. Then the second part of the management is that renal failure was promptly treated with dialysis. Usually we see the dialysis, the nephrologists are little bit maybe telling us to wait. But here I could see within the third, I think on the third day itself or within 24 hours of the oliguria and other things, the patient was given the hemodialysis and it was repeated on alternate day and she recovered from the renal failure. That was a very good point that the termination of pregnancy promptly taking precautions and then management of the renal failure very efficiently and the correction of the DIC which has, the coagulation defect that has come and then recovery of the patient. So hypertensive disorders is still contributing to maternal morbidity and mortality. Dr. Hariprasad was very correct in telling that the patient who had previous 2 cesarean with FGR 1.8 and 2.28 and recurring, it could be a recurrent preeclampsia, early onset preeclampsia or even an autoimmune disease like APLA syndrome. So we have to, if it is APLA, she would have benefited by low molecular weight heparin as well as with aspirin. So we do not know. That was a chance to correct. And as we said already, the prophylaxis with aspirin in this case after screening. Don't give aspirin to everybody. It's not the way. We can screen at least with the history, physical examination and a properly taken MAP will give you the result, a better pickup than not doing anything. So that was stressed enough and more by Dr. Hariprasad and we are should make use of offer all screening for everyone. They may do it, they may not do it. I said offer to every screening, including aneuploidy screening. Now don't take the NT measurement is equal to aneuploidy. You have seen, unfortunately, if it occurs, you may be questioned why you haven't done the proper screening. You offer them. So NT is not equal to aneuploidy screening. We have to do the other biochemical also. So I think overall we are happy. I think we are seeing the result of our efforts for the last 10 years or so. 10 years back, we would have lost this patient, but we could see these cases are being managed very well, barring some of the things in the suboptimal care in the first, during the early period of pregnancy, which I am just not criticizing anybody, but we should see that we should make it a point to screen the patient for all these problems. And then you offer them. If they do not do that, is a different issue. But try to do this, and things can be managed. And we do not know whether this seriousness of this case could have been reduced by proper screening and starting the treatment as such. So one important thing is that they have ruled out a placenta previa, anterior placenta previa. That was located. It was on the posterior side. That is the other thing in a previous cesarean or previous 2 cesarean. The risk we have seen many cases of placenta previa accreta coming or the syndrome, but that was ruled out anyway. That was noted. But again, a patient who had a 2 FGR previously with 1.8 and other things, we could give importance to that point with the history of the CVA for the father. Again, whether there is any familial thrombophilia, other things could have been looked into. But anyway, finally, we are happy that patient is saved with a very great effort of everyone. It's a team effort. We are helpless without the help of nephrologists and other colleagues and gastroenterologists. So we are going as a team. Everybody is helping us, and the importance of getting a cross consultation is important. And Thank you once again that it was very well managed, but barring the initial suboptimal care. Thank you.
Thank you, sir, for your valuable suggestions and suggesting the learning points. Now we invite Dr. Vishwanath, gastroenterologist from Thrissur HOD Professor, Thrissur Medical College, for giving us more insight into the liver function abnormalities of this case. Welcome, sir. Dr. Vishwanath.
Sonia, Vishwanath sir was not able to join, but he has sent me a message. I will read it out. Sir said an apology that he is not able to join. He was trying for the past 30 minutes, either through the phone or through the laptop. Somehow he is not able to join. And what he has said is, here, the onset of hypertension. He has sent me a voice message, just whatever he felt after reading. And he also said that discussions will be fruitful if he can join live on time after hearing what others can say. Anyway, whatever he has said, I am reading it out. Here, the onset of hypertension is at 30 weeks. And a week later, she presented with high BP, vomiting, and epigastric pain with impending signs, and a week platelet dropping, and transaminases increasing to 1000 level. The total picture is suggestive of a HELP syndrome. However, in the early part, the evidence of hemolysis is less definite. The hemoglobin drop came only later, and the peripheral smear did not show any schistocytes or burst cells. Any hemolytic cells was not seen. The evidence of hemolysis also came later on. However, here the most probable diagnosis is HELP syndrome only, though the alternative possibility could be an AFLP. But he has said it is HELP syndrome. And the great thing about any near-miss case is it's a learning art. We can learn we can learn from each case. And here, sir said the onset of management was quite speedy. The speedy action, the decisive interventions, and the team management. All the three things work together to bring the patient back to life. And sir says the crucial thing in antenatal care is BP monitoring. At least in the third trimester, has to be very careful about BP monitoring. And any patient who develops an abdominal pain should be taken as a warning sign and immediately do platelets and liver enzyme. Just a minute, sir is calling. Hello, sir. Okay, sir. Okay, sir. Okay, sir. Then sir, the message. Okay. Okay, sir. Okay. Okay, sir. Sherry, sir. Okay. Okay. Sir said he is quitting from the meeting. He was able to listen to whatever we said. So what he said is, any patient presenting with hypertension, presenting with abdominal pain, immediately a liver enzyme and a platelet has to be done to detect the early complications. That is sir's message. I think, Sonia, you can continue with the...
Okay, thank you, madam. And now that the patient has gone for acute kidney injury, I invite Dr. Vimala, a pioneer in nephrology, to tell us more about this patient and this management of renal failure. Welcome, madam.
Good evening to all. Thank you, Dr. Lakshmi, for this wonderful opportunity. I think I'm audible.
Yeah.
Yes, ma'am.
Okay. Many points which I wanted to say had been highlighted by my previous speakers, But the first point is congratulate the team for the wonderful effort and getting the patient discharged out of the hospital. But could you have prevented all this? That is the main issue. As Professor Hari Prasad had pointed out, I also feel that the referring unit should have stabilized the blood pressure with injection labetalol before referring, because the time is very crucial. It was a malignant hypertension, though we have not been given the fundoscopic picture. Any blood pressure more than 180 by 110, we manage as a hypertensive emergency, and we should, especially in pregnancy, we should give parenteral labetalol, get the blood pressure down before referring. If she had produced a seizure and intracranial bleed, probably you wouldn't have been able to save her. That is the first point I would like to highlight. The second point is, having diagnosed HELP syndrome, when you take a patient for emergency LSCS, time and again, it had been suggested by the nephrologist that the patient should be given prophylactically FFP and platelet infusion before the patient undergoes LSCS. So in Kottayam, along with Shamla Madam, we had wonderful work. We had been working together, and there was many papers from Kottayam which suggested that had overall reduced the incidence of acute kidney injury postpartum after the delivery. Here, having diagnosed HELLP syndrome, probably we were little late in giving FFPs, platelets, and cryoprecipitate. Had we given it earlier, probably the hyperperfusion to the kidney wouldn't have been this much, and the renal failure would not have progressed. That is the second point I would like to highlight. The third point is the second post-op day, the GFR is normal. That is, creatinine is 0.6, potassium is 6.3. So whenever somebody has got a normal creatinine and the potassium is high, we have to exclude a pseudo hyperkalemia, especially when the patient has got a hemolytic anemia. The potassium may be spuriously high, but you have to do a simultaneous serum and plasma sample to make out whether it is a true hyperkalemia or a pseudo hyperkalemia. If we are not able to make out it's a pseudo hyperkalemia, what we should have done was, instead of waiting for a consultation, it is a medical emergency, it is a silent killer. The treating unit should start the anti-hyperkalemic measures immediately. I don't know whether they have done that. There is no mention of any hyperkalemic measures. They said that nephrologist was consulted and started on anti-hyperkalemic measures. The other point which I wanted to make was, whenever you encounter, the ECG report is also not there. Whether the ECG showed any evidence of hyperkalemia is also we have to consider. Though AKI progresses to dialysis requiring AKI in HELP 40%, this patient probably had an underlying sepsis, as evidenced by significantly elevated procalcitonin and a CRP. I checked, pregnancy has no influence on procalcitonin level. So if the procalcitonin is high, that means there's a bacteriological infection going on. We are not able to figure out what is the source of infection, but the renal failure, they have been worsened by sepsis as well. So probably what is the source of sepsis? How did she get infection? We do not know. Probably we should have started her on. There is now, we say the de-escalation of antibiotics should be done than escalation. Whenever you have a complicated case, when sepsis is suspected, you have to start with a powerful antibiotic and then de-escalate. So I think the management was very good. So we had a wonderful outcome. Thank you for the opportunity once again.
Thank you, madam. One doubt. Should we give FFP even if the coagulation profile is normal in case of HELP syndrome?
Yes, usually. If the HELP syndrome is diagnosed before any intervention is done, it is better to give at least 1 or 2 units of FFP. That would prevent the further complications.
Okay, madam. Thank you. Now I call upon Dr. Prasanna, madam, to give us the concluding remarks. Madam, please. Prasanna, madam.
Yes. Let me repeat what Hari Prasad and Sharon sir said. Whenever a pregnant patient comes, we have to take a proper history. And this patient's history is very much suggestive of either some chronic underlying disease or APLA. So she should have been investigated at that point itself. And I think if with a woman with such a history, should be referred to a tertiary center. He had 2 previous cesareans and both done for severe IUGR and oligoamnios. So she should have been referred early, even before she develops hypertension. And all patients, as Sharon said, all patients should be screened for aneuploidy as well as hypertension. All patients. And this patient especially. The uterine artery Doppler is written normal, but that is not the thing. She has so many other risk factors for preeclampsia. So that opportunity has been missed. And about the referral, I also feel that the blood pressure should have been brought down by intravenous labetalol and then only refer. So in case she had developed a cerebral hemorrhage, we would not have saved the patient. So that is, I think that it is IV labetalol. There is nothing to be scared of giving IV labetalol. Only thing is you have to give it slowly. and then stabilize the patient and refer. In the referral center, actually, as all of them said, she was managed properly. But whenever such patient comes, we have dealt with such patients, a lot of such patients in medical college, and sometimes it's very difficult to say whether she has, as Professor Vishwanathan said, whether she has AFLP or HEP syndrome or preeclampsia with severe features. Whatever it is, there's an overlap. Whatever it is, the management is termination of pregnancy and management of liver failure or renal failure. Both can kill the patient, and coagulation failure. So when such a patient has a very high BP and abnormal liver function, this patient, she developed all the severe features after cesarean. So whenever you do cesarean for such a patient or she delivers, postpartum, she should be investigated. We also recently had a patient with not much very high BP, but postnatally she had headache, and we found her with this like this 220, 170 BP, and we had to give her IV labetalol and magnesium on the third or fourth postnatal day. So usually it recovers after delivery, but sometimes she can go for severe disease, both in HELP syndrome as well as AFLP. So she has to be investigated after delivery. This patient is properly managed after delivery, but I think the renal failure was diagnosed by, 30 ml in 12 hours. So whenever such a patient who had severe BP undergoes cesarean, her output should be monitored hourly. Otherwise, we don't know when she will go for renal failure. So it should be a urometer where you can measure every hour urine output. That's very important. And she has to continue the antihypertensives. Sometimes, one BP reading is normal, they will discontinue the antibiotic. That we should not do. We have to continue the antibiotic. And it was nice that they have started Eprisol, which is a vasodilator, and it dilates the renal blood vessels and reduces the, improves the renal function. And this dialysis. And what about this plasma exchange, Vimala?
Plasma exchange has no role in HELP syndrome, but you are diagnosed liver failure. Now they say plasma exchange, as doctors say. But this is
What
a clear
about
case of HELP syndrome, but the proof of the pudding is in eating because she has resolved. Otherwise, we should have thought of HUSCT something like that.
Liver function improved and renal function deteriorated. But the
And
CM
one point
TMA,
you highlighted was very important, which wanted to say, because you have to always connect this patient to your uroflow, and early urine output monitoring is mandatory. This 500 ml, we could pick up early stages of AKI. That's a very good point, Prasanna.
and in such patients, this AFLP and HELP syndrome, if she goes into a severe disease, we have to repeat the investigation every 6th hourly. Otherwise, we don't know when she will go for coagulation failure, when she will go for acute liver injury, when she will go for coagulation failure or renal failure, like that. So we have to repeat the investigations every 6 hours till she shows a resolving trend. We have to repeat the investigation 6 hourly. And another thing is, we don't know whether it is AFLP or HELP syndrome. And if recently I went through a case sheet of maternal death, and I found that the patient was deteriorating. Her liver function was deteriorating, and every day it is written, it has become like this, she has gone into coagulation failure, etc., etc. But nothing was done. Actually, that at that point of time, they should have planned a liver transplant. Liver transplant centers are everywhere now. Gone are the days when liver transplant we have to go somewhere else. Here, even in Trivandrum, there are several centers doing a liver transplant. So if the investigations are showing a deteriorating trend, we have to plan liver transplant, to refer the patient to a center with liver transplant, so that that can save the patient. Maybe very rare, but recent that case sheet, I was remembering about that case sheet. That patient could have been saved if the timely liver transplant might have been done. And about renal failure, repeated dialysis, and we have to think of it. And usually we resort to a multidisciplinary team. And usually the nephrologist, gastroenterologist, everybody comes to our help. And we thank all of them. Because of them only we are saving all lives. And about this patient's opening the abdomen was difficult. Sharon sir was telling about the vertical incision. And this patient had several additions between the uterus and peritoneum. And that is all because the cesarean is not done in the proper way. That's what I feel. And we have to inculcate that culture of doing cesarean slowly in the proper way so that these type of additions will not occur. And I think that will reduce the incidence of placenta inrita as well. Placenta inrita as well we get reduced. Then such a patient, post-operative period, this patient had thromboprophylaxis. We cannot give heparin because her coagulation is abnormal. And she was given DVT pump, etc. That is admirable. And we have to give. And Vimala, if 40,000 platelet and she is undergoing hemodialysis, for the hemodialysis, does she need platelet?
No, we do a heparin-free hemodialysis actually. Monitoring
Then of course this patient was given platelet-rich plasma also, and I think
Okay.
it's unnecessary. It's unnecessary because if 40,000 platelets, if no bleeding, or she is not going to be taken
No,
for another
that's not the
surgery,
question.
then of course,
No, no.
platelet
FFP is
transfusion was
because
not
that
necessary.
can produce bleeding. You want to
That
prevent
can.
further bleeding.
Platelet transfusion was not necessary. And another thing I wanted to say is, I forgot what it is. A postnatally evaluation. This patient may go in for hypertension later life. This patient may be having APLA. So postnatally, she should be given after the coagulation failure is over. She should be given heparin, and her long-term follow-up. Long-term follow-up is important.
What do you think have been a source of sepsis here?
Sepsis, peritonitis, maybe peritonitis because abdominal distension, and that is what I forgot to say. She was having abdominal distension and Riles tube was put by the surgeon. So it might have been an infection in the abdomen.
Yeah.
So that might have been the cause for the procalcitonin.
Dr. Prasanna, can I
And
stress
another
one
thing is
point?
that
No, so
sometimes, it's difficult to make out whether it is AFLP or HELP syndrome. And peripheral smear, as Dr. Vishwanathan said, it will help you in seeing whether there is hemolysis. And haptoglobin also. Haptoglobin will decrease. Will decrease if there is hemolysis. That will do whether it is HELP or AFLP. There's no point in differentiating, of course.
treatment is immediate delivery.
That is saying.
Can I stress one point, Dr. Prasanna, can I stress one point?
Yes, sir. Oh, very much, sir.
No, just
But,
for
you asked me
reminding,
that,
just one point, it was said one or two times by Hariprasad also. When we just diagnose hypertension, don't start on some hypotensive center. She has to be investigated. Now, this gestational hypertension diagnosis is not static there. It may progress to preeclampsia. Until unless you look for proteinuria, look for evidence of other organ dysfunction, you are stuck with hypertension only, but it can progress to preeclampsia or the worst situation that has happened. So I don't think that we should put a diagnosis of gestational hypertension at all without investigating thoroughly that none of the systems are involved by investigations. There is no proteinuria on repeated examination, then gestational hypertension may have a milder course and you can wait even up to 37 weeks. But in cases where it is a preeclampsia, things are different. The complications are more both for the mother and baby. So I think just by seeing hypertension, and secondly, in this case, even though blood pressure can shoot up within no time, I am afraid whether the BP was missed earlier in a patient who had a recurrent preeclampsia sort of a syndrome or placenta dysfunction earlier in the both the pregnancies, and then suddenly 280 by 170 or so. Probably we have to be very careful in checking the blood pressure. What else we can do as a obstetrician? What else we are doing? we are delegating this responsibility to the junior-most person, but they should be trained how to take a proper blood pressure. Always it is 110/70 is not on. So be careful in checking the blood pressure of a pregnant woman properly taken. I think the mercury apparatus are to be thrown out, but you should have calibrated other equipments to take the proper BP. So that has to be very carefully seen, as even the gastroenterologist is reminding us that you should check the blood pressure properly. So that is an important clinical assumption which gives a very important clue to the progress of the patient, the progression of the disease. So suddenly here 270/170, 260/110 or 140, whatever it is, suddenly may not go up. In a patient who was diagnosed to be having hypertension, as said that she has to be monitored well, she should have all the investigations done and then carefully monitored. If the BP is controlled, then only probably you may send her to home with a frequent visit. Otherwise, she has to be in the hospital. So here she was not properly investigated for preeclampsia, I hope. It should have been done. And then just putting the diagnosis of gestational hypertension and sending her with some oral drugs, and suddenly patient come with all these complications. So that we have to be very careful. Hypertension in pregnancy is a killer. We lost many patients, but in this case, she didn't go to that level. Thank God to everybody's effort. So very interesting case to learn so many things in this case, including the initial screening and other things with the history and in this particular case, and then all the complications that can develop in a preeclampsia. Differentiating points, we need not go, because as Dr. Prasanna said, whether it is HELP or AFLP, the delivery is the treatment, immediate delivery. But if you are theoretically so much concerned, then you can go for the biomarkers. The biomarkers like SFLT1 and PLGF will be raised. SFLT1 will be raised and the PLGF will be less than 10% in the range to say that if it is preeclampsia. Otherwise, it will be normal in AFLP. So that may be a sort of academic interest only, but practically it's not. But if you want to really differentiate with these conditions and hypertensive disorder, that is the way. You can go in for a marker. Now it is very sensitive, it is available, it is being done in Kerala also. So we have to be knowing such things are available.
From the nephrologist point of view, if somebody has got massive proteinuria and there is no hypoglycemia occurring, we are tempted to think in terms of help. If the patient does not have significant proteinuria and there is hypoglycemia, we are tempted to think in terms of AFLP. As sir has correctly said, the management is terminal. I would like to ask you, sir, there are some fetal calculators I'm just going through. Are they available in India? Are they doing it? That is placental growth factor.
It is available.
Associated plasma protein.
It is available. It is available. It is available. It is available at Calicut also by Roche Diagnostics. It is available. Only thing they are having a high cost, which we were trying to negotiate. Actually, the cost is not that much, but the lab, once it is initially being marketed, they are charging more. It is all available. The SFLT PLGF ratio can be done. Only thing is it is costly because it is going to 1,500 to 2,000 for one S, and it has to be done repeated if you want really.
Repeatedly it has to be done.
It has to be repeated. One value may not help unless it's so severe and needing termination. If it is SFLT and ratio is too high, more than 85, but if it goes to 200 and all, that needs termination. That is another way of assessing the seriousness of the preeclampsia. So it is all available. If we start using it, probably they may reduce the rate also. I had an opportunity to talk with the company person, but they said if you can have more cases being done, we can reduce the rate. But as such, it is nearly 2,000 rupees, one estimation.
Thank you.
So it is available, madam.
Even if it's not done, both the mother and as well as the fetus can be monitored by other means.
Yeah, that is true.
It may not be done. Okay.
May not be done, but making decision. See, timing of delivery in preeclampsia is most crucial thing. In all cases which we lost, the timing of delivery was delayed. patient died of HELP syndrome, again the delay. Patient died of eclampsia. We had the equal number cases of eclampsia coming in. That means the timing of delivery is delayed. So the timing of delivery can be detected by the ratio. That will help us if you start practicing it. So everywhere the delay in delivery is the cause of death. Having diagnosed it, so you do not know. If you do it early, then you are getting a preterm baby. If you are waiting for the maturity, then you are losing the mother even. So the crucial thing is the timing of delivery in preeclampsia, which may be helpful to use these ratios and all, which is being done in India, not only abroad. In India, it is all being done. In Bombay, it is almost become a normal practice. We have tried to get it, and they have brought it to Calicut. It is there. We hope we will be able to utilize, and provided they reduce the rate. Okay.
And we have to give importance to prevention also. This
Yeah.
patient aspirin, early aspirin.
Yeah.
Prevention, proper history.
Yeah.
And very carefully monitoring the patient if the BP is 140/90. Again stressing.
Yeah. Yeah.
Don't give a message over the phone, WhatsApp message, you take this or do this. And don't let the patient get the BP checked in local hospital. Let her come to the hospital. Local hospital, somebody will take the BP and report it as wrong.
Those
Wrongly normal.
who are caring a pregnant woman, so BP check. So that is the minimum. Whoever is caring the pregnant woman should be knowing it. Otherwise, it's not antenatal care.
All my patients do home BP monitoring.
They can, if they are trained. If they are trained with a calibrated equipment, if they are trained, because it is all being done abroad. It is, they are told, the leaflets are given to them. So we have to have the calibrated equipment, and then it is all available. Everybody from Gulf, when they are coming, they are bringing an BP apparatus. Only thing is, it has to be calibrated. So it is all easy. Now almost everybody who is coming from Gulf is bringing a BP apparatus also. So it's not that we are not having such an apparatus, but I think the public is having it. So let us make use of all those things.
Sir, I think we are going short of time. Time allotted for the first case is
Next case
over.
mostly discussed in
I know
this
it was a very good discussion, but the second case is also important. So with your permission, can I ask Sonia to present the second case, sir?
Yes.
Carry on.
Okay, madam.
Carry on.
Okay, madam.
Second case.
Okay, madam. So, can you see the slides?
Yes.
So, next, second case. This is a 23-year-old T3P1L1 previous FTND with LCB 3 years back. She was admitted 29 weeks and 3 days of gestation. She became near miss on the same day of admission and was discharged after 18 days. She was referred with lower abdominal pain and back pain since 1 day. Her antenatal period, she was uneventful except for moderate anemia with HB 9.1, detected in second trimester, evaluated, and HPLC showed sickle cell trait. Coming to obstetric history, she had first was a missed abortion at 6 weeks, which was managed medically. Second was full-term normal delivery, female baby 2.25 kg, 3 years old. There was no comorbidities. She belonged to a tribal community. And on examination, examination revealed there was icterus, there was no pallor. Systemic examination was within normal limits. Her RBS was 49 milligram percentage. And obstetric examination showed 30 week size uterus, cephalic presentation. Uterus was non-tense and non-tender. FHS was good. Cervix was long with closed doors. There was no dating scan was not done. Her USG at 12 weeks of amenorrhea showed a single live intrauterine pregnancy, 16 weeks gestation. And anomaly scan 4 weeks later showed normal interval growth and there were no anomalies. Coming to the investigations, her hemoglobin on the time of admission was 10.7. Her TC was 18,300. Platelet count and RFT was normal. Her total bilirubin was 5 gram percentage with a direct bilirubin of 2.7. And SGOT and SGPT was highly elevated, 3,740 and 3,640 international units per liter. Her total protein was 5.5 gram percentage. Albumin was 2.8 and alkaline phosphatase was 300 international units per liter. URE was NAD. LDH was also elevated in the 1010 international units. And APTT was 43.3. Prothrombin time was 120 with an INR of 11. So coagulation profile was grossly abnormal. So she had elevated leukocyte. The investigations showed elevated LDH, leukocytosis, raised LDH, SGOT, SGPT, total bilirubin, and abnormal coagulation profile. She was shifted to labor room HDU on the same day. Antenatal corticosteroid was given for lung maturity. Medicine consultation was done. She was diagnosed with as acute liver injury with coagulopathy. Her investigations already discussed. 4 units of FFP was transfused and post-transfusion INR was 3.4. Initially it was 11 and prothrombin time was 35.9 and APTT 33.1. Gastroenterology consultation was done, diagnosed as acute severe liver injury, advised to continue supportive management. Her hepatitis A IgM and hepatitis E IgM test was negative. So provisional diagnosis was acute fatty liver of pregnancy. And same day night, she was induced with PGE2, the indication being AFLP. At 2 a.m. on next day, her cervix was soft, mid-position, 75% effaced, 2-finger loose, BOM foaming, ARM done, draining, grade 1 MSIF, and there was no cord within reach. Vertex at -3 and pelvis was normal. 5 units of cryoprecipitate was given. Oxytocin augmentation was started at 2:15 a.m. And at 4 a.m., cervix was taken up 6 cm dilated, membrane absent, draining grade 1 MSI, and vertex at 0 station. At 5:03 a.m., she delivered a preterm female baby weighing 1.385 kg vaginally. Laker was grade 2 meconium stain. Baby was admitted in NICU in view of preterm delivery and low birth weight. And on first postnatal day, she had icterus. Pulse rate was 126 per minute. BP was normal. Respiratory rate was 17 and GRBs was 160. Chest was clear. Per abdomen, uterus was 16 weeks. Bleeding PV within normal limits. And there was no calf muscle tenderness. Output was adequate. It was managed with antibiotics, injection cefuroxime, rifaximin, and injection vitamin K and tab UDC and other supportive measures. Gastroenterology review done. Their impression was acute fatty liver and advice followed. Her investigations showed hemoglobin. Her investigations for hemoglobin 8.8 gram percentage, which was initially 10.7. Her TC was elevated 21,200, which was 18,300 initially. Platelet count was normal and RFT was also normal. Total bilirubin was 5.1 gram percentage and direct 2.4, which was there was not much change in bilirubin level. And SGOT, SGPT was 1,394 and 2,262, which was showed a minimal decrease. Initially, it was in the 3,000 range. Total protein was 5.6 and albumin 3 gram percentage. LDH was 678. APTT was 34. PT was 39 and again 3.1. Initially, it was 43, 120 and 11, showed a marked improvement. USG abdomen on postnatal day 1 showed no evidence of heteroechoic areas and moderate ascites was present. Patient was tachypneic and drowsy. ABG showed improving lactate and high anion gap metabolic alkalosis. Serum ammonia was elevated about 257 and repeat ABG showed worsening alkalosis. At 5:15 p.m., she was shifted to ICU in view of encephalopathy and coagulopathy. Patient was monitored and supportive measures given. Total transfusion include 9 unit FFP and 5 unit cryoprecipitate. On postnatal day 2, patient was drowsy. Pulse rate was 117 per minute. BP was normal. GRBS 111. Chest was clear. Abdomen was mildly distended with ascites was present. Bleeding BB was within normal limits and baby was in NICU and output was normal. But investigation showed HB was 10 gram percentage, TC 11,000. Total bilirubin 5.3 and 2.5, which was remained almost same range. SGOT, SGPT was 1,497 and 1,175, which almost not much change. And INR was also prolonged. PT was 61.7 and INR 5.44. Previously, it was 3.1. So, coagulation profile abnormality worsened. On second postnatal day, anti-hepatitis A virus IgM ELISA test was positive. Initially, it was CAR test was done, which was negative. Now the ELISA test became positive and other viral markers were negative. Gastro-medicine review done and diagnosed as acute viral hepatitis leading to acute liver failure. Patient was then taken over to gastro-medicine department at about 11 a.m. on same day for further management. This is the investigations. On third day, the hemoglobin, TC, platelet count, RFT was normal, but bilirubin showed an increasing trend. On postnatal day 3, it was 7.3, and SGOT, SGPT showed improvement. SGOT was 229, SGPT was 789. On postnatal day 5, the bilirubin also was high, but the enzymes showed a decreasing trend, 59 and 260. On postnatal day 10, the bilirubin continued to increase, about 10.2, but the enzymes 55 and 19, 50, and postnatal day 15 also, bilirubin there was only slight decrease, 9.4, but the enzymes were almost within normal range. Was in the hospital, she was taken over to gastro-medicine side in view of acute hepatitis A related acute liver failure. Poor prognosis was explained to bystander. On receival, patient was drowsy, not obeying oral commands. There was icterus, per abdomen was soft. Blood culture on admission was sterile and urine culture showed growth of E. coli. She was managed with IV antibiotics, initially with piptas and then changed to meropenem and linezolid with anti-liver failure measures and anti-edema measures. Neurology consultation was done and advised to continue same line of management and to do CT and EEG once patient stabilizes. Sensoring gradually improved and by day 10, she became conscious and oriented and she was shifted to step-down ICU. On postnatal day 18, patient was discharged. So the final diagnosis, T2L1, acute viral hepatitis A, acute liver failure, coagulopathy, and hepatic encephalopathy. The near miss category, 1.3, incidental and accidental causes in pregnancy, infection. The near miss criteria, the infection being viral hepatitis. Symptoms and signs include altered conscious state, encephalopathy, tachycardia, tachypnea. The investigation showed HIV IgM positive, elevated serum bilirubin more than 6 milligram percentage, abnormal liver enzymes, abnormal coagulation profile. The interventions include ICU admission, 4th and 4th generation antibiotics, blood and blood product transfusion more than 5 units. So this is a case of acute viral hepatitis in pregnancy leading to coagulopathy and encephalopathy, which was managed well by multidisciplinary team and patient was discharged in good condition. So the case is over. So now the case can we go to the discussions? I call upon Dr. Shekharan to give the expert opinion on this case. Shekharan, sir.
Thank you, Sonia. The nice case again. Here again, it is a very rapid progression of the condition of the patient. She just came with abdominal pain, and then she was jaundiced at that time. She was evidence of clinical evidence of jaundice, and on investigation, one of the things was, even though liver enzymes were very much raised, transaminases were raised, she was having hypoglycemia. Now that was the point where we thought of ALF. That is very typical. The liver enzymes will be very high, and because of the hepatic damage or cellular damage at the cellular level, the gluconeogenesis and glucosynthesis may not happen, and she will go in for hypoglycemia. That was very typical in this case, and we thought of ALFP, and the viral markers were negative at that time. Naturally, it is to be taken as a case of acute fatty liver of pregnancy, which is a very rare condition, but a serious condition, rapidly progressing condition. So again, here the termination of delivery is the treatment actually, so that the patient will recover. And if that happens, usually the patient takes about 1 or 2 weeks for the complete recovery. That is the course of events. Now, acute fatty liver of pregnancy is an defect in the enzymatic process of fatty oxidation, especially long chain fatty acids. And in the fetal side, the fetus may be having that homozygous mutation, and baby cannot handle that abnormal products of the incomplete fatty oxidation, and that comes to the mother, and that is said to cause this toxic effect on the abnormal metabolites increasing in the maternal side, leading on to this deposition of the product fatty chain in the liver cells, and that produces all these acute symptoms of hepatic failure, leading to even the cerebral complication of the patient going for encephalopathy. So here, termination of pregnancy is the treatment with the supportive measures, correction of the hypoglycemia. If necessary, she can develop all complications, including coagulation defects. So here again, we have to see that the patient's general condition is looked after, simultaneously the timing of delivery. Here it was very effectively and very energetically, she was induced at the 29 weeks. Luckily, she could respond to that induction, and she delivered within, I think, within 24 hours. I think it took not much time. So that's a good thing. At 29 weeks to get an induction successfully, and she delivered, avoiding a cesarean section, because in ALFP, actually the acute fatty liver, the incidence of cesarean section is almost 50-60%, because the cervix may not be favorable, and the condition of the mother also will be deteriorating, and somehow to deliver her is the treatment. So many cases are taken for cesarean, and then usually she will recover. But here, after delivery, the liver condition was progressing. I mean, the pathology was progressing even after delivery, but it may take some time for the recovery. It may take even weeks. So it may be the natural course, but she deteriorated, and she was going for encephalopathy, and by that time the viral marker has come positive. So the termination of pregnancy, even if it was a viral hepatitis, would have helped to have less load onto the strain onto the liver at a later stage when the pregnancy and the delivery occurs, and probably the early termination would have helped in this situation also, even though we have done it for acute fatty liver pregnancy. And subsequently she recovered. Now, acute fatty liver pregnancy can have problem for the baby also, and we may have to have the checking of the condition for whether it is any mutations there, if you really want to check this. Another thing is that in the subsequent pregnancy, there is a recurrence of acute fatty liver is also reported, and hence you have to advise the patient, counsel the patient accordingly. And also sometimes the baby can have serious problem, because they may have sometimes going for the failure, hepatic failure, even for the baby. So we have to probably warn all those things, and the later chance of her developing acute viral hepatitis, of course, we will have the viral markers positive. Here it may not be there. The transaminases in both conditions, it will go up. But in HELLP syndrome, the transaminases may not go to that level compared to the hepatitis of acute fatty liver as well as viral hepatitis. But the coagulation failure can occur in all the conditions. So it is all becoming the same sort of a triage of presentations with liver failure progressing in a different way. Here again, the delivery is the treatment, and in acute phases where the patient is not recovering, there is a place for liver transplant. And then liver transplant, in this case, I think there is a place that you keep that patient's liver kept there at such, and do some, I don't know what it is done. You do the liver transplant, hoping that her own liver will recover, and that will be functional later on. So they don't remove that, I don't know the technical details. So they say, keep that liver, do the transplant, and afterwards you remove the transplanted liver. So I think Vishwanath will be able to help us. I just saw this in one of the publications. So that is, the place for liver transplant also is there, but this particular comment is there. So we will get clarification from Dr. Vishwanath. Okay.
Thank you, sir. Lishmi Amman, Dr. Vishwanath sir join ചെയ്തിട്ടുണ്ടോ?
ഇല്ല സാറ് ജോയിൻ ചെയ്തിട്ടില്ല. സാറ് വോയിസ് മെസ്സേജ് അയച്ചിട്ടുണ്ട്, ഞാനത് വായിക്കാം.
Okay.
Sir has said, I am sad that I don't have the chance to interact with the audience and the faculty. It's only, what I'm saying is only from the data given to me. In this second case, acute liver failure in the setting of pregnancy. The first diagnosis is AFLP. So the decision for delivery is immediate delivery is fully justified. It must have been later that the hepatitis virus was positive with ELISA. Initial one done was with the card. By and large, hepatitis A does not affect pregnancy itself. Hepatitis A, B, C are believed not to affect the pregnancy adversely. Exception is viral hepatitis E. Hepatitis A, B, C, they affect pregnancy in some way, that is, they cause some preterm labor and delivery, but the outlook is not bad. In this patient, the platelets had remained normal and the enzymes were, the rise in enzymes were in thousands, not only in simple thousands, around 3,000 and above. Thus is the hallmark of viral hepatitis. A rise, such a huge rise in liver enzymes is the hallmark of viral hepatitis, though this much of rise can also occur in ischemic hepatitis or paracetamol-induced toxic hepatitis. It is not common in AFLP or HELP syndrome for the enzymes to reach above 1,000, though in the first case we have seen just now the enzymes were quite high. And prothrombin PT change was, prothrombin time change was also significant. Fortunately, the patient did not develop the complications of a increased bleed. She was, I should say, she was ably supported with blood and other component transfusion. According to the data, hepatitis A and RNA virus, the hepatitis E that causes mortality, but epidemic hepatitis of A has occurred in PGI Chandigarh when Sir was studying there. He has seen many cases of hepatitis A in pregnancy. And in Kerala, an epidemic of hepatitis A occurred in 2024. Maybe he attributes it to the poor hygiene and other things. And they had around 2024, they had around 10,058 cases diagnosed. It is in not only in pregnancy, outside pregnancy, everything put together, 1,058 cases diagnosed, and the mortality was 37%. And he also said this is not specifically in pregnancy. And the suspected cases were much higher. These were all the diagnosed cases, and the suspected cases were much higher. In pregnancy, around 150 cases were reported. These are all unpublished data, out of which 15 turned to be very severe cases. And what Sir wanted to stress, the other point Sir wanted to stress was that this patient had a hyperacute liver failure. That is, the onset of symptoms to liver failure, the duration was less than 1 week. And generally, fulminant hepatic failure, the duration to set in, it takes around 6 weeks or even longer. This here, the worsening has happened within a week. And what we observe is, when the worsening is fast, the recovery is also fast. And if you are hang on to the patient, managing hypoglycemia, coagulation problems, and see to it that she does not develop an raised intracranial tension, the patient can be saved. These three things, that is hypoglycemia, coagulation problems, and a raised ICT, are the main killers in fulminant hepatic failure. The liver will recover promptly and the patient will survive, provided you are able to address these problems and prevent these problems. And he said, I still believe hepatitis A is not harmful till we get sufficient data to prove that it does. If worsening is fast, as in this patient, the recovery will also be fast, but try very hard and the patient will rally round. He has congratulated the team, and the care which was given to the patient was brilliant. And he also emphasized that near miss cases is a positive thing for us to learn more and more. And sir, he is not there to clarify the doubt about the liver transplant. Maybe I'll ask him and tell you, sir.
Okay.
Now I invite Prasanna Madam to give the concluding remarks.
Hepatitis, such a patient comes at 30 weeks with a history of jaundice, nausea and vomiting, and we have to investigate her. Her BP was normal, 110/70. That means it is something related to liver only. We have to take a proper history because sometimes she might have been having some fever and she was dehydrated. She can have ischemic hepatitis, or we have to go into her personal history. She might have taken some poison. So this elevation, that all that can produce even paracetamol overdose can all cause hepatic failure. So proper history is important. This patient gives a typical history of viral hepatitis. So all the viral markers should be done, and it should not be CAR test, it should be ELISA, and it should be it should include E also, because hepatitis A will not produce that much problem. This patient's E, I think it was not done, isn't it?
It was done, madam. It was negative.
Negative, okay. It is E that causes serious problems. And then that is about the proper history when the patient comes. And then investigation, of course, liver function test, test of coagulation. This patient's PT INR was 11, and so lucky that she survived. 11 with 11 INR, mortality is almost 100%. So she survived without a transplant. So that we and when we manage, nice that her pregnancy was terminated, even though it is viral hepatitis, because pregnancy is a risk to the liver, a stress to the liver. So even though it was wrongly diagnosed as AFLP, even now we can't say whether it is AFLP itself. Pregnancy was terminated and she promptly responded. Even though at 30 weeks, she promptly responded. If she doesn't respond, then of course we have to take her for section. And that section, we have to arrange a lot of blood and products. And when we when we manage the patient after delivery, as I have previously said, the investigation should be done frequently, every 6 hourly, because this patient, fulminant hepatic failure, she has gone into. And she is a patient who might have needed liver transplant, which can be done. Even if the PT is 11, they will do that's thromboelastography and give products, and they will do the transplant. That's what they say. They can do the transplant and save the patient. And I think Sharon sir said transplant is done and then the transplanted part is taken away. It is for the time being that they do transplant for such patients to tide over the crisis. So we have to think about it. We have to plan that. And if the liver function, this patient responded and gradually she improved. If she had not improved, definitely she is a patient for liver transplant. And you have to arrange for that. You have to shift the patient to a transplant center. You have to plan it. Unless you plan, you won't be able to accomplish the transplant and saving the patient. This patient promptly responded and her liver function improved and recovered fast, as Professor Viswanathan said. So she didn't need any transplant. And one thing I have to say is, even when the patient comes with hyperemesis, we have to give her sufficient fluids. See that she's given intravenous fluids, she's not taking orally, and B complex, thiamine, etc., to prevent this wernicke's encephalopathy. So we have to think about it. Sometimes, pregnancy with fever, there also we have to think about hydrating the patient. Otherwise, she can go in for ischemic hepatitis, even though it's very rare. We have to think about it, hydrating the patient. And when we manage these patients also, proper fluid management is important. And Dr. Vimala is there? Vimala is gone. So proper fluid management based on now they see the IBC and then IBC compression and distension and then manage fluids. Fluid management is very, very important. And acute fatty liver, again, fetus also can have complications. Fetus also should be followed up, and he can have a recurrence of acute fatty liver in the subsequent pregnancy. So we have to counsel the patient regarding subsequent pregnancy. So I think everything has been covered.
Madam, the answer for Shekharan sir's question from Vishwanathan sir.
Yep.
As sir said, as he already emphasized, what Shekharan sir said is about is known as a bridge transplant. A bridge transplant. You transplant and wait for the liver to recover. And interim period, what you do is a bridge transplant. You don't transplant the whole liver, only a part of it, even sometimes half of the liver. But he said these are all a little bit of hypothetical experimental situations, have not come into vogue as such. But what sir said is, in this case, this is a case of hyperacute liver failure which has occurred within a week's time. They do better with medical management. And the liver transplant in this case is a solution, provided it is a delayed liver failure, which usually occurs after 1 week, maybe 2 weeks, 3 weeks, 6 weeks, like that. In that case, the patient has to be referred to, has to be in a hospital setting where liver transplantation possibilities are there. Then sir said, it is very difficult to find a donor for a liver transplant, and it really takes time. And so it will be difficult in the Kerala settings to get a transplant, to get a liver transplant done in such cases. But then
It's
the
being
liver
done
failure.
in Trivandrum Medical College.
And madam, sir പറയുന്നത് കണ്ടുപിടിക്കാൻ
hepatic failure transplant ചെയ്യുന്നുണ്ട്.
ഉണ്ടായിരിക്കും മാഡം. സാർ പറഞ്ഞത് കണ്ടുപിടിക്കാൻ മെഡിക്കൽ ഗാസ്ട്രോഎൻട്രോളജിസ്റ്റ് അല്ലേ പറയുന്നത്, കണ്ടുപിടിക്കാൻ പ്രയാസമാണ്. പെട്ടെന്ന് ഒരു ഷോർട്ട് നോട്ടീസിൽ കണ്ടുപിടിക്കാൻ പ്രയാസമാണ്.
പറയുന്ന പോലെ അത്ര എളുപ്പമല്ല, എളുപ്പമെന്നല്ല ഞാൻ പറഞ്ഞത്. ഇറ്റ്സ് ബീങ് ഡൺ ഇൻ
ലിവർ ഫെയിലിയർ അക്യൂട്ട് ആയിട്ട് വരികയാണെങ്കിൽ അവർക്ക് ട്രാൻസ്പ്ലാന്റിന് പോകേണ്ട കാര്യം, വിത്തിൻ എ വീക്ക് ലിവർ ഫെയിലിയർ സെറ്റ് ഇൻ ചെയ്യുകയാണെങ്കിൽ നമ്മൾ ആ മെഡിക്കൽ മാനേജ്മെന്റ് ഓഫ് ദോസ് കോംപ്ലിക്കേഷൻസ് ചെയ്താൽ മാത്രം മതി, പേഷ്യന്റ് എളുപ്പം തിരിച്ചു വരും എന്ന് പറഞ്ഞു. ആൻഡ് ഡിലേഡ് ആയിട്ട് ഫെയിലിയർ വരുന്നവർക്കാണ് നമ്മൾ ലിവർ ട്രാൻസ്പ്ലാന്റിനെ പറ്റി ചിന്തിക്കേണ്ടത്. ഓക്കെ മാഡം.
ഗുഡ്. ഡോക്ടർ ഹരിപ്രസാദ് എന്തിനാ ആഡ് ചെയ്യണ്ടെന്ന് ചോദിക്കാം.
Lot of features in the initial clinical settings itself suggestive of hepatitis etiology rather than acute liver failure of pregnancy, because usually acute fatty liver of pregnancy presents later in the third trimester. It is little bit earlier, that is before 32 weeks.
Yeah.
And also the viral hepatitis usually milder course usually. But in this case, since it was a rapid progress of the viral hepatitis, a hepatic failure came little bit earlier. That is the only thing. And also marked leukocytosis, normal platelet, normal renal function, and high levels of OTPT are usually suggestive of, they are not the usually expected in AFLP. These are the different, the initial setting itself, there are a lot of features against the AFLP. But since the patient deteriorated fast, the delivery is optimal.
Yeah.
And after the delivery, the patient deteriorated, but the supportive measurements started promptly, and the patient came out gradually.
Yeah.
Any
Sir,
type of
actually,
liver failure, any type of liver failure can have hypoglycemia. So this patient's liver
Yeah.
failure because of hepatitis, she had hypoglycemia. That's all. And she didn't
If
have abnormal
rapid
renal function, she
progression,
didn't have hypertension. So it's typical of viral hepatitis only.
Yeah.
But even with a PT-INR of 11, she survived. That's way.
survived.
Sir, I don't know whether it is because of the link problem. We are not seeing any questions in the chat box. But then Dr. P.K. Shamala has sent me a message that somebody was asking about postpartum BP monitoring. Madam said all women need postpartum monitoring 5 to 7 days following delivery. There is an entity called de novo postpartum hypertension.
Yeah.
We are not seeing the chat box. I don't know why there's no question, but I think Madam from the delegate link has seen this and she has sent a message.
Okay.
Postpartum monitoring anyway is very, very important. And postpartum sometimes she'll worsen and she'll go for HELP syndrome, eclampsia even.
About 10% of patients normotensive usually develop hypertension in the postpartum. Usually there will be some edema and a headache. These are the two symptoms. We have to give antihypertensives for that and monitor.
We say that in hypertensive disorders, initial 2 days, the BP may become normal. And because of all the fluids return to the vascular system, there is usually a BP rise by the 4th day after 3 days and also 7 days. So the BP has to be checked at 4th day and 7th day, and also teach them about the impending signs. Any impending signs to report immediately back to hospital. Anything more to add? Otherwise, I think Vimala Madam has come back. Madam, are you there?
Yes, I am there, Lakshmi. But I
Oh,
don't think
but-
I've got anything to contribute because everything has been well said. I've been listening. So I have nothing to add.
No, Prasanna Madam wanted to ask you something. What is that, Madam?
No, I was telling that fluid management, it's
I-
important. When will you prefer half normal saline?
Lakshmi wanted me to give a discussion on
Yeah,
that.
talk
Only,
on
Prasanna.
Yeah.
Other
Yeah.
you can fix a date. Okay.
Yeah, we'll fix a date.
And
Okay.
most probably next month, June. May, it's
Okay,
already
fine.
fixed. Yes.
Okay, no problem, Lakshmi. You give me 1 week notice.
Okay.
Okay.
Madam, sir, then can we wind up the session if
Okay.
there
Thank
is?
you. Thank you.
We will wind up. Let me thank Dr. Lakshmi Ammal for arranging, for conceiving the idea of this Case Connect series and arranging all these, making all the slides and putting all the efforts and conducting all Mdnmsr meetings all around Kerala. She joins in all the webinars, and let me thank profoundly Dr. Lakshmi Ammal for doing all this.
That is my duty, Madam. I am the state coordinator. It's my duty.
Let us reduce preventable maternal death to 0. Let us all together, all gynecologists of Kerala together, reduce the preventable maternal deaths to 0.
But our attendance
Thank you
was not
all.
very good. 275. 2,600 gynecologists all over Kerala. We just had 10% attendance. We should do something to improve.
200 something, in between there was 200 something participants.
275, Madam, 275.
Okay.
That's good number because many webinars are going on. many program are going on. So 200 plus is very good. 270 is a really good number. Everybody may not attend, but those who are attending are always attending and doing. So you want everyone to be there, because these points what we are discussing are important in the day-to-day practice. So it will be useful for everyone. I have learned a lot today by attending. So let us hope to learn again and again, continue to learn. Okay, thank you. Thank you, Dr. Lashmi, Dr. Prasanna, thank you. Okay.
Thank you all the experts, sir. Thank you, Shekharan, sir, the Prasanna Madam, Dr. Hari Prasad, Vimala Madam, and then of course, Dr. Vishwanathan. He was feeling very, very bad that he's not able to join and contribute fully.
We are losing that wonderful chance of learning with him. Anyway, thank you.
I was also waiting to learn about hepatitis from
Thank you, Dr.
Vishwas, sir.
Vishwanath, for your comments. Anyway, we have learned something, of course, even though we could not see you and interact. Thank you, Dr. Vishwanath, for participating.
And Dr. Sonia, thank you for the nice presentation.
Yes, please.
Thank you so
Dr.
much.
Sonia, thank you. Nice.
Thank all the delegates also for remaining late, and still we had till the last moment, we had around 187 people listening. Just 15 minutes before it became 187, otherwise it was above 200.
Yeah.
Anyway, Madam, we are going to come back. The Maternal Safe Motherhood Committee is going to come back with a webinar on sepsis with Prasanna Madam, with Dr. Aravind. Combined, we are going to present a webinar. Madam, May 29th. May 29th. We'll be back. We will try to improve the attendance, Madam.
Okay.
Somehow I'll try.
Attendance, I need the only improve.
It's good.
Okay.
Not bad. Okay, good.
So I'm thanking everybody who participated. Let us all together reduce the reducible maternal death.
Shekharan sir, tea time ayo ode. 5 mani ayo sir. International faculty ആണ് sir appo.
5 o'clock, exactly 5 p.m.
Okay.
Okay.
ചൂടാണോ സാർ അവിടെ? മോള് പറഞ്ഞപ്പോൾ ചൂടാണെന്ന്.
ഇപ്പം നല്ല ക്ലൈമറ്റ് അല്ലേ, വെരി ഗുഡ് ക്ലൈമറ്റ്. എവറി ട്രീ ഹാസ് ഗോട്ട് ഇറ്റ്സ് ലീവ്സ് ഉണ്ട്. മറ്റേ കമ്പുകൾ മാത്രമേ കാണുള്ളായിരുന്നു. പ്ലെന്റി ഓഫ് ഫ്ലവേഴ്സ് ഓൾ അറൗണ്ട്. സോ എൻജോയിങ് ദാറ്റ്. Okay, anyway, thank you very much. We'll be joining you in the next meeting.
Thank you, sir.
Thank you.
Good night.
Good night.
Good night.
Lakshmi, leave yellow.
Madam. In the madam?
Leave yellow.
Chair.